Cool. Thank you, Ashley. Thank you, sponsors. And was I the only one that heard that Ashley turned like one of the chipmunks?
She sounded like Minnie Mouse for a hot second
I
there.
thought it was only me because no one, Phil was laughing, but no one,
I was
everyone else was
I
pretty
saw
straight
it.
face.
I
So I
heard it.
thought, what the hell was going on there? Well, we have a great night, everybody. This is a fantastic meeting we're going to have tonight. We'll get to our special guests in just a moment. Phil, introduce yourself real quick.
Hey, everybody. Phil Page from Baton Rouge at Fran U. Shout out to all my peeps from Fran U here, all my students attending, and I'm glad you're here. And thanks again to our sponsors, of course, Kevin and Dr. Dugas.
Yep. Go ahead, Barb. You're next.
Barb Guggenboom. I'm the editor-in-chief of IJSPT, repping Grand Valley State University in Grand Rapids, Michigan. Again, really big thanks to Kevin and Dr. Dugas for being here tonight and sharing your knowledge with us. Thank you.
No doubt. No doubt. All right, Kevin, do you mind introducing yourself and our special guest?
Sure. Yeah, I'm Kevin Wilk. I'm at Champion Sports Medicine in Birmingham, Alabama, which is a select medical facility. I also work at the American Sports Medicine Institute, which is our biomechanics lab. And I'm really pleased that Dr. Dugas from Andrews Sports Medicine Orthopedic Center in Birmingham here is able to join us. Dr. Dugas and I have worked together for, I don't even know, maybe 28 years or so.
Oh yeah, 27.
And he's also the team physician for the WWE. Professional wrestling, also Troy University, and Jeff, if you want to expand on that at all, it's all yours.
No, that's you could go on and on. That's plenty. Thank you.
We might
Thank you for having me.
Yeah, you're welcome. Thanks for joining. I bet we could talk for an hour just on the WWE.
It's an interesting gig. Been with them for a long time. They're a fantastic bunch, and among my favorite athletes. They're very professional and easy to work with.
Yeah, I bet. All right, let's get started. What do you guys have a preference? You okay starting with the I think it's pronounced Rilk. That's the one with Dr. DeFelice. DeFelice, is that how you said it, Kevin?
Yeah, DeFelice.
DeFelice.
So let me give a little color on that. Interesting. Yeah, Greg and I were classmates in residency. So as such, that's like being in the military, a little bit like being in the military together. You hunker down, you have to take a few bullets for each other. You get fired upon. It's a team firing. That's the way residency is. And so we were classmates. And it's interesting that 25 years later, we are the two people that really popularized two of the more up and coming and more recent internal brace techniques, me in the elbow and Greg in the ACL. And I will highlight a really important component of that in terms of UCL repair in the elbow and ACL repair in the knee. I'm in Alabama, and Jim Andrews is my mentor and senior partner. And I have to say, I was surrounded by people like Buddy Savoie and Mike Siccotti and Neil Elatrosh and all these really talented elbow surgeons that supported me in that process. And Greg was in New York City at HSS. And even though he's done a lot of research, Greg was not as well supported through that process. And it took longer for Greg's stuff to get out there and really find the mainstream. But he stuck with it. And he and I have communicated about this all the way through the process. And even though they've been very paralleled, they've been very different. And Greg's an impressive guy, and he's a real scientist about it. And he has a passion for it. So I always applaud Greg. And I don't think he gets the credit he deserves for really bringing this to the forefront scientifically. So as a classmate, I got to say cheers to my friend, but he really has done a good job with this. So.
Well, so to start off, do you mind? You could probably relate this to the elbow that you do this with, but can you describe kind of the understanding of the different preservation techniques for ACL?
Sure. So everybody's familiar with ACL reconstruction, which is one of the best operations in the history of orthopedics. If you look at it in terms of return to play. There aren't many things that we do that have a higher rate of return to play in athletics than ACL surgery. It's 95, 96%. So it's truly a great operation, and it's been around for a long time. And even though the techniques are a little varied, they're effectively the same. You drill two tunnels somehow and you put something in there and fix it. And if you put it in the right place, you rehab them right. And obviously it's a very rehab centric experience, and the rehab is certainly key. And I think we all go through these phases where we try to get people back quicker, and and then we realized that was a bad idea, and then we kind of back off from that. So I think that the more senior you get, the more you realize that that whole ego thing about getting them back quicker is really a bad idea. But anyway, the preservation things have really come on in the last 10 to 15 years, more so even in the last 5 years. And I think there's been attempts at repair. And if you look back at the history of ACL surgery back in the 70s and 80s, John Fagan and Bill Clancy and Lanny Johnson and these kind of early fathers of sports medicine, Ken DeHaven, all these guys, they were there when we were talking about how to fix the ACL, and Jack Houston and Jim Andrews. So they tried repairing these things. That didn't work very well. And remember, in those days, all they had was suture, and they didn't have fiber wire and super suture, and they didn't have anchors, and they didn't have fiber tape and collagen coating, and they didn't have 40 years worth of experience with the rehab and the where to put the thing and all these cool new toys we have now that allow us to do the operation and understand it better. And then you fast forward, they went through the LAD, the ligament augmentation device, which was this disaster of a procedure that put effectively a carbon fiber device in the knee, and that destroyed knees and destroyed cartilage. And so we went through all these iterations of failed procedures, and reconstruction came out on top, just like the UCL did, because they tried repair with the UCL too. And Frank Jobe and Jim Andrews figured out that didn't work very well. And so they panned that in favor of reconstruction very wisely. And so the reconstructions came out on top for all the giants in our profession in both the knee and the elbow. Well, now we've got better stuff. We have super sutures, we have anchors, we have tape, we have collagen coating, we've got anchors that'll withstand just about anything. And so we've got much better tools, much better toys. And that's when the idea of repair, not in the terms of what they did back 30, 40 years ago, but in new terms with newer stuff, became an idea again. And I think that the parallels between what happened in the elbow and the knee are very similar. It's better for end avulsions than mid-substance ruptures. It's better for people who aren't going to be, in the knee. They've kind of come to the point where they say it's better for people who are over the age of 21. Well, what happens over the age of 21? Well, people are out of college. I don't think that there's going to be a whole lot of NFL and NBA team docs that are going to be doing ACL repairs real soon. There'll be one. It'll happen, and they'll have one because of a timeline issue or a career, ending issue. That's what happened in the UCL. People said, "Oh, this is not for high velocity people. It's not for the Major League Baseball guys." And I said that too. That's not why we did it. But it's held up to people throwing 105. And there's a good chance that one of the top 2 or 3 draft picks this year had it last year, had it a couple years ago. And so we're seeing it now at the major league level. And I think the same thing will happen in the ACL. But it's got to overcome a lot of ego and a lot of dogma and a lot of people throwing tomatoes at you saying this is a bad idea until we figure out where it fits. And it's maybe not going to have the 96% success rate of getting you back to play at the same or higher level in the high school and collegiate athletes. But it probably will have that rate of success in the casual athlete. And so why not take a chance on a 3-month recovery with minimal bone destruction and minimal tunnels and minimal, recovery, less pain, faster return to work, all these things. And that's really what Greg has said. And Greg has a very low ego about this. He'll be the first one to say it doesn't work for everybody, and you really got to be patient specific, just like we did with the elbow. So I think he gets criticized for thinking this fits all ACLs. He does not say that. And that's really what this paper, this paper really says. It's not for all of them. So that's kind of a background and a current look at it.
It says it's really for proximal tears, right? Mostly. And proximal tears, is that the least common
No,
ACL
that's the
tears?
most common. The distal tears
Proximal is the most,
are
okay.
less common. The mid-substance and proximal ruptures are more common.
Okay, I thought mid-substance were the more
Mid-substance are
common
the
than-
most common, but the proximals are more common than the distals.
Yes, yes, okay, that makes sense. So is this really essentially like your internal brace for the UCL? Is the core, like they describe a core suture, is that really the same thing, or is it?
Not really. You know, in the internal brace, we're taking the ligament and repairing it back to bone with like an anchor and a simple suture, similar to what Buddy Savoy did and published on in the mid 2000s. With this, they're actually whip stitching the ligament with a super suture and then dunking an anchor with that suture kind of attached to it into the bone, into the prepared, you know, attachment of the ACL, and then augmenting it with a fiber tape, which is kind of similar to what we're doing. That's the latest iteration of it, the way you see it in this article. Originally, it was just repair with a super suture and an anchor. There wasn't an internal brace.
Oh,
Greg then went to internal bracing it because the simple suture is probably not going to hold up to some of the stresses of early PT, which is obviously one of the hallmarks of success with ACL surgery. So I think it's our experience with, you know, immediate PT and immediate range of motion probably hurt the ACL repair world a little bit early on. And then they came to this kind of newer version with the internal brace, which is a more rigid construct. So they could push them a little quicker.
got it. So one of the I got a question for Kevin in just a minute, but Doc, for you again, that they talked about tissue quality being a consideration for doing it or not. How are they grading tissue quality for someone who tore their ACL? What is that? I don't. I'm guessing probably a lot of us therapists may not know how you grade tissue. I mean, it's torn, right? But
Yeah.
is there an objective way to measure ACL tissue quality?
I would say it's not as objective as you'd like it to be.
Okay.
But to me, when I do ACL repair, when I even consider it, it's somebody whose MRI really appears that the ACL is torn completely off the femur. I don't see a stump. It's not that gray appearing heterogeneous looking stuff on an MRI where it really doesn't look like ligament at all. It's just this gray crud. With a torn ACL that you can fix, it looks like an ACL and it almost goes in the same direction up towards the, up towards the wall, or it may be stuck to the PCL, but it looks like the ACL is there. And when you go into those knees, you put the scope in there, it's an ACL. It may be scarred to the PCL. It may be sitting up by the wall, but you're looking at a bare wall. You're not looking at a stump. You're looking at a bare wall. So you've got a lot of ligament to play with. And you realize there's not, and the best way I can describe it is there's not a tissue deficiency. So I wouldn't say that it's necessarily the quality of the tissue. I think that's probably important. But if there isn't a tissue deficiency, you've got all the collagen you started with, and you're just sticking it back to where it came from. And you're creating, you're shaving the bone so that it'll bleed. So you really are creating a very positive and beneficial environment for that. And the healing in that area is very robust. You get a really robust healing response there. So I do think that there is a spot for this. The other thing that I didn't bring up is the Bear procedure, which is the biologic enhanced ACL repair, which is a wrap effectively that you put around a torn ACL. And that's more being, I think that is settling into a mid-substance rupture in the pediatric population. I don't think that the data supports doing that in a highly functioning, like even a housewife, house husband skier in their 30s. I don't think Bear is necessarily what I would reach for. I think that it's not met that standard in terms of athletics and agility. I think in the 5 or 6 year old, 9-year-old, where drilling tunnels has really got some negative to it, doing the Bear and getting them to an adult form when you can have the adult form of the operation is so not invasive and good. And I do think that that's where Bear is going to end up finishing its journey I don't think it's going to find itself in the milieu of regular ACL reconstruction.
Those are most done.
Whereas I think repair probably will.
Yeah, I remember seeing there was a study, I don't remember how long ago, it was maybe 5 or 10 years ago. There was a study from, I think it was from Italy, where they did it sounds very similar to this, but they did microfracture up in the femoral notch, and it was for proximal tears only.
Right.
And they said the healing was good and people got back to sports. Is shaving, like you were describing, shaving the bone off, is there any benefit to shaving versus microfracturing the bone? Is it essentially doing the same thing?
I think you're doing the same thing. You're getting access to the marrow contents. You're you're creating a bleeding surface. So I think it's the same. You know, you're getting this biology there that's going to help heal.
6-1/2.
Dr. Stedman talked about that for
He
quite
did.
some time before he passed
Right.
away, and had done it even with elite skiers with these proximal tears that were incomplete. He would do a picking procedure, and he actually had scopes. Remember, Jeff? He had
Yeah,
scopes.
he did.
He showed afterwards, like several months later, the healing response, and obviously some people didn't believe it. Somebody we used to work with took
Yeah.
exception to it. Not
Yeah.
Dr. Andrews, someone else, but
Yeah.
Dr. Stedman was a pioneer in a lot of ways and a true gentleman as well, like Dr. Fagan and others, and
You
wouldn't
know,
mislead you in any way.
Yeah, and I think when you're dealing with people at that level, I mean, you're talking about elite of the elite, right? I mean, sometimes these guys can go with less than. I'm always astounded at what elite athletes can do, and how you look at them and you think, okay, that may not be the best knee of all time, and then they go out and they win, you know, whatever they win, and you can't compare them. So when I have a kid come in and say, oh, you guys did Adrian Peterson's knee, and he was back in 6 months.
Yeah.
And, you know, that's why I'm here. I always make the point that if I was to stand Adrian Peterson here next to you, you would notice some immediate differences between them. And you are not now, nor will you ever be Adrian Peterson.
Yeah, yeah.
And you cannot equate the two of you. Your bodies are not the same. And
Hey, Jeff, is there any concern when you do repair it back proximal about any shortening of the ACL? You know, years ago when I saw the first repair, like 84, 85, I mean, it was a bear, no pun intended as far as bear procedure, but it was very difficult to gain flexion. Extension wasn't a problem, but flexion, it seemed like it almost was like a misplaced graft anterior. It was just really tough. Any concern with that? Is there a balancing act with the surgery?
Definitely. And I think that is a experience thing. And I have not expanded in my own clinical practice into ones that are, you know, type 3s or type 2s that are, you know, 25% of the way down the ligament and advancing the ligament. I just don't feel good about that. The ones that are really off the wall, that are, you know, 95+% of the length of the ligament is there, I think that those are not a bad option for this, but I haven't personally expanded that. I don't think you've seen that from me, but I think that people are expanding that. And I think that just like with all these things, somebody has to expand it and see the successes and failures in order for the rest of us to figure that out. And I think Greg has been very honest about, yeah, I don't think that mid substance is the way to go. Has he had success with it? Sure. Would he say that it's great for that? I don't think he would. I think a low demand person with a internal brace in their ACL and the mid substance, yeah, they might do fine. But somebody that's going to try to be, you know, real agile on it, I just don't know that I'd feel good about that.
Kevin, I was just thinking about your birthday. We got to tell you happy birthday, right? You just mentioned that you saw your first primary repair in 84, 85. I just want you to know I was still in high school when you saw your first repair, ACL repair.
Well, I was a child prodigy. So I actually skipped high school. I went right to college. I just tested out, so I'm actually very young.
I think Kevin looks great for 75. I just think
he does. He does. All right, Kevin,
man.
question for you. The description. Have you seen these repairs? Have you seen people that have had these repairs?
I've seen Yeah, there was a big gap. So like in the mid 80s and even late 80s, I saw when I worked in Chicago. And
Mhm.
then just recently, I've got a couple, not from the group here, the Andrews group, but actually from a physician in Atlanta. So I've seen two over the last couple of years that
Okay. So
proximal,
this,
just like Dr. Dugas said, same, there was a lot of ACL left and it was just a few sutures put in and it was really immediate motion and everything. I mean, it's like almost like a reconstruction. I mean,
that's what I was
it's
going to ask
rock
you.
and
Is
roll.
the rehab, because the description of the rehab in the paper is really pretty vague. Do you rehab these people differently? Do you slow them down any? Do you speed them up? What do you do?
Well, like any time, when you get somebody from an outside referral source, you like to, pick the physician's mind a little bit and ask them what their preference is and try to follow suit, obviously. And in preparation of this, I asked Dr. Dugas to get a hold of Dr. DeFelice to see his protocol. And here it is right here, as a matter of fact. So, we've looked it over and I've talked to Dr. Dugas about it. And I was really, quite impressed with one, the completeness of the protocol, but two is the lack of restriction. I mean, it's motion to tolerance, full extension right away, no knee extensions ever, but closed chain exercise right away, quads, and very criteria based. So Dr. DeFelice and his people up at HSS did a very nice job with the protocol, and I think I can speak for him, Jeff. I think he's willing to share that protocol with anybody that.
He is
Yeah,
absolutely, yeah,
yeah.
no question.
Nice.
I've
Bill,
got one coming up, Kev. I'm doing one Tuesday that
there
I
you
think
go.
we're going to repair, and a 37-year-old who she's pretty active, but I'm doing one Tuesday, so you may.
Okay, I'm ready.
You're ready to go. Phil, Barb, you got any other questions before we move on to the next paper?
Nope.
No?
I just have to say that I suffered through the labs as the rehab person when people were doing those in Grand Rapids, Michigan, and it was a Charlie Foxtrot. It was horrible. Yeah, so I'm old enough. I'm almost as old as Kevin, but I'm old enough to have seen those LEDs, and it was bad.
That was
It was not
bad.
good.
Yeah, that was rough. If you ever see one of those knees, like for a knee replacement, it's just black and gross, and it's
Oh, no.
yeah.
Yeah, and one more thing about the internal brace, Rob, if you don't mind. So we've
Yeah,
had
yeah.
our baseball meeting, ASMI, American Sports Medicine Institute. We run our baseball meeting every year in January. Dr. Dugas, one of the chairmen, as well as Dr. Kane and Andrews and Emblem. And it was overwhelming consensus, the internal brace for UCLs. I mean, we had our meeting in Chicago, in New York, Dr. Ahmad's meeting as well, and then midwinter meeting for baseball in Nashville. So those are the three big meetings, and all of them said the same thing. So again, just so the participants realize there was a time when the internal brace was really scrutinized at the elbow and all this, and now it's mainstream. It's either a hybrid or internal brace, and occasionally a reconstruction. Obviously, you did one yesterday on a wrestler I saw this morning
I
with a
did. Yeah,
graft. So
he has
Louisiana kid, as a matter of
no
fact.
ligament. His ligament
Yeah,
is gone.
yeah,
Hey, guys,
yeah.
we have some questions from people listening. So I'll give you one here from Mark, our friend Mark Paterno. Is there a window of time from the date of injury that it's safe to do the ACL repair based on tissue health, possible retraction of the tissue, or any other issues? I guess that's for you, Doc, maybe.
Yeah, I would say that 4 weeks is kind of the outside on an acute one. You will occasionally see the tissue scar at a good length. You've heard the term pseudo stability, where the ACL scars the PCL and they get kind of the pseudo stability. Yeah, maybe there's enough length and you can peel it off the PCL and retain the length. I actually would worry about the tissue quality at that point, because that tissue at that scarring location, the PCL, probably isn't great. So I actually personally think 3 weeks and less. So I'm gonna be out kind of a couple of days, surgery days, and I've got this girl that looks like she might be good for it. She tore her ACL on Saturday, and even though Tuesday I'm probably going to end up doing this at 8 o'clock at night, I think it's in her best interest to have it done Tuesday rather than wait another week for that exact reason. So I think that there is biologically, and Greg actually says that in his article, really 4 weeks is kind of the outside, and that's based on him doing 700 or 800 of these things. So he has the data to support the idea that timeline matters. So I would say in the 3 to 4 week range.
Okay. Kevin, Patty Trila looks like is asking. I think you said no. The protocol said no knee extension, and she said no knee extension forever, or is there a certain time frame where you allow knee extension?
Well, I was just quoting Dr. DeFelice's protocol. So for us, we do knee extensions from 90 to 40 right away. I don't really have a hang up with it. My hang up is from 40 to 0. My hang up is heavy resistance and terminal. My hang up is people with a lot of ligamentous laxity. My hang up is grafts. We're not talking repairs now, but grafts that aren't really biomechanically sound. So those are my concerns, and also pushing heavy weight. You know, it's one thing a couple pounds going to terminal knee extension. It's a whole nother game when there's 40, 50 pounds on an isotonic machine. So for me, there's a window to this, whether they're reconstructed or repaired, and it's going to be probably around 3 or 4 months before I let you go all the way up. Now, we certainly do terminal knee extensions in closed kinetic chain, weight bearing, with squats and lunges and leg press and step downs. And I mean, elevated rear squats. I can keep going, but I won't.
Name them. Yeah. For you go on forever.
Right.
Doc, this is another question for you, I think, from Sarah Tyndall regarding tissue collagen quality. What considerations are there to the fact that many athletes are nutrient deficient in a lot of areas due to heavily processed food diets, both at home and at school/college? So does diet play a key in any of this?
So, Sarah, that's a tremendously great question. I think that nutrition plays an enormous role in virtually everything we do. And I think there are so many things that see us that we don't see. And I think a lot of those things are in the nutritional, vitamin deficiencies. I'm using the word vitamin broadly, but, could be heavy metal deficiency, could be vitamin deficiency, could be collagen deficiency, could be metabolism deficient, could be gut things, could be. I think there's so much of that sees us that we don't see. And I don't think that we healthcare, we medicine are at a point where we can easily evaluate or recognize that enough. But I think that that's something that we as healthcare need to push, because I think it can't possibly hurt. It can only help. It's one of those, there's no downside. It's all benefit and no risk. And I do think we're going to find solutions to some problems that see us if we dig deep enough into that. So yes, I think you're exactly right.
Especially with the female, especially with the female athlete, unfortunately.
Absolutely.
Body image is important in certain sports like gymnastics and cheerleaders and
No doubt.
even basketball to that level, where so I think that's a major concern, especially if you're taking care of teams, you're at the high school level or college level.
No doubt.
Man, I mean,
I work with USA Cheer. So I'm the medical director for USA Cheer. I work with cheerleaders all the time, which thankfully I was not a cheer. I think I dated a cheerleader once, but I was not a cheerleader. But
careful.
But yeah, there's not a story there. But I also, working with Troy University. Troy is a small town with lots of fast food, and our football team, we have to really, all of our athletes, we got to really control that. I work with the USOC. WWE actually has 2 nutritionists that work with a grand total of about 100 people, and they're obviously they're into physique and appearance, but they also travel 52 weeks a year. They spend a lot of time in hotels and airplanes, and they're in all kinds of bad environments all over the world. And we pay a lot of attention to their nutrition and their hydration. And these people manage to go 52 weeks a year, and rarely, they do have injuries, knock on wood, but they don't get hurt as often as you'd think. So I do think that's a really great question. I can't highlight that enough.
I do want to point out, Doc, real quick, that when Buddy Savoy was on a couple months ago, he spent a lot of time talking about the supplements that they're given through Tulane, particularly when they're doing those reconstructions as well. So if you're interested in that, take a look at our YouTube channel for the replays. I don't remember what month it was, December or November.
I don't remember either. I can go back and
look.
But they gave you the whole cocktail.
One of the most brilliant human beings I've ever had the pleasure to know, and I'm fortunate to call him a friend. He is a leader among leaders, and I think he's exactly right.
Yes, sir.
No doubt. All right, one last question, Doc, before we move to our next our next study here. How would, this is from an anonymous attendee, how would you know from a clinical standpoint if one of these fails? I ask because I have one that is 10 weeks out, starting to complain of anterior medial knee pain, and has laxity with the Lockmans. It kind
Yeah,
of
I would say
spells
it
it out.
probably failed.
Yeah.
It's a clinical entity, and I think that I say this, if maybe one day when I'm gone, my fellows will all get together and have this put on my tombstone, and that is, don't treat the image, treat the patient. If they're unstable, they're unstable. And it's not a criticism of the surgeon. It's not an emotion. We all get emotional about our patients, but everything has a failure rate. It just, if it's unstable, it's unstable. Move forward, solve the problem, and move past it. So I think you just got to treat the patient.
Good point. That's an excellent point.
Doesn't
All
matter
right.
what the image shows.
You guys got anything else before we move to the next paper? Everyone good? Ash, you ready to move on? Yeah. Okay. So the next paper is I think it's Stephanie Philbay, healing of acute anterior cruciate ligament rupture on MRI and outcomes following non-surgical management with the cross bracing protocol. So, Dr. Dugas, tell us what's different about the cross bracing protocol. How's it different than what we were talking about before?
This is a European study based on the idea that you put somebody in a knee brace in maximum flexion for 6 weeks and keep them there on crutches and allow their ACL to heal. And they showed, I think, 90% success.
It's pretty good. Yeah.
I don't see in their paper how they defined success. I don't see a lot of athletics. I don't see a lot of patients that we see. I don't think the population is the same. So there's clearly some population differences. Also, in Europe, in a lot of different places, there's a lot of physician determinant of success rather than patient determinant of success. And that's not a criticism of the European system. That's the way it's always been. We get a lot of great data from Europe, and they often lead us in a lot of ways orthopedically. I think this would be really hard to sell to a patient. I wouldn't do this. I couldn't sell this to a single patient if I had to. I could literally, you're basically making them an above knee amputee for a week, for 6 weeks.
Yeah, 4 to 6. Yeah.
I'm not saying that to be crass, or I don't want somebody saying you're being unsensitive to the above knee amputees, but you're putting somebody in effectively maximum knee flexion. They have to sleep like this. They have to walk around like this. They're on 2 crutches. You're effectively taking away their lower leg. And I couldn't talk somebody into this even if I had to. So I'm not sure how this is a system where people were kind of obligated to. I would wonder if there were people who didn't agree to this and who those people were, who said no to the study. There's only certain places in the world where you can randomize somebody to this kind of treatment. We could never do this in the United States.
Yeah. I was
Yeah.
wondering about that myself, because it sounds horrible.
That was a problem, Doc. They didn't randomize this study. They just
It's a
it was
case
like
series, a big
case
old
series.
case.
Yeah.
Mhm.
And if I remember correctly, the success was something like as little as a third
It was.
of
Right.
repair was actually seen on the MRI.
That's right.
So there was no the success wasn't long term or whatever. It was just what they saw at the MRI at 3 months, I think is what it was. So
And I think they only had 1 year follow-up. The
Yeah.
average follow-up was 1 year, which is not, it's hard to get something published in our literature with 1 year follow-up, especially in the ACL. It's the most published injury ever. We're not going to get something published with 1 year. They had small, relatively small numbers, and you're right, they weren't randomized. So I think their methods, I think this is one of those papers, and I actually think it's great that we get to talk about this. I think methodology matters. And I'm not a fan of levels of evidence. I think levels of evidence is one of the worst things that's ever happened to surgical medicine. Levels of evidence were designed to keep drug companies from pushing things past us. And you can't randomized, double-blind, placebo control a surgical procedure. You know, you can't have level 1 evidence. And also, what works best in your hands as a therapist? Kevin, what works best in Kevin's hand may be one thing, and what works best in Phil's hands may be completely different, and Rob's hands, and they may be different, but they may globally achieve the same goals. Ultimately, in a surgeon's hands, if you don't know how to do what this study says is the only way to do it, but you know how to do it another way and your outcomes are good, you should not change how you do it just because the article says so. You should do what's best for your patient always. And so I think levels of evidence, we've gotten caught up in that. This is not methodologically great evidence. And I think that if you're being critical of a study, you got to be critical of the way this study was created. Do I think it's interesting? And do I think there's likely going to be a patient in my life that I think we should try this because it can't hurt? Somebody that can't possibly have a surgical procedure. They're too much of a risk. Their surgical risk is so high you can't do it. Great. This is a good study to say, put your leg in flexion for 6 weeks and you should be okay. And I'll do that. I would recommend that based on this.
You should be okay on your MRI, right?
You'll be okay on your MRI.
Exactly.
You'll at least be okay.
You know, a couple things that kind of strike me about the study, the report. It's interesting. One is they're restricted for 10 to 12 weeks. That's a big commitment right off the bat. Not only locked at 90 degrees of flexion for a month, but the other aspect is they said no sports for 9 to 12 months.
Yep.
So if you're going to dial in 9 to 12 months and take a risk, for me, and again, this is just my logic, whatever it's worth, I'm going to go what gives me the greatest success, which is a reconstruction. Why do I want to take a chance if I'm an athlete, whether I'm recreational, high school, or pro, 9 to 12 months? And if it doesn't work, that's another 9 to 12 months. So it's 2 years of my activity level. The other thing that's a little bit interesting in the paper is the first week they put them on anti-inflammatories. Why would you do that if you want the thing to heal? It's a little bit of a contradiction, unfortunately. And then the other point that I just wanted to bring up, I don't know if you're aware, I know, Jeff, I sent you the video.
Yeah, I remember.
It was on NBC National News.
Yeah, it was.
In California, talking about this because he felt as though the success rate with ACL reconstructions wasn't very good, and this was a viable option, and he's recommending it to his patients. So I think people need to be aware that this is being thought about and maybe even employed by some physicians around the world, not just in Australia, but also here in the States, perhaps.
I have no doubt. My biggest concern anytime you see something like this is a little bit like when JBJS put the first lead article saying knee arthroscopy didn't work.
Yeah.
And then they had to go retract that. Knee arthroscopy has never been held out as a great solution for arthritic knees, and it isn't. But that doesn't mean you publish as the lead article in JBJS that arthroscopy is a bad procedure. You got to take these things in context. People that say that rotator cuff tendons shouldn't be fixed. Okay, how many people in the panel and how many of the physical therapists are going to say, if I tear my Achilles tomorrow, I'm not going to have it fixed? Why would you make the same decision for a rotator cuff or any other biceps tendon? I mean, the same thing. 95+% of people are going to say, fix that. That do what we do for a living, all of us together. When that kind of level of professional support goes into something, you got to figure there's something to it. ACL surgery is widely successful. When people come to me, this happens to me all the time, probably happens to you guys too. Reps and companies and industry will come to me and they want to change. They want to make a change. They want to say, hey, use this for your ACLs. Well, why do they come to you? Why are people working on improving ACL surgery? Well, I mean, I get it. It's great. They work on it because it's so lucrative. There are so many of them. If they can even get 10% of that pie, that's a giant number. But when you come at me with a way to improve ACL reconstruction as a procedure, to me, your level of ability to succeed is so small because it's already one of the best procedures in the history of orthopedics. So you're coming at me asking me to make a change to something that globally works really, really well. And I was with Andy Williams, who's the team doc for basically all the Premier League soccer teams. I was with him in San Francisco this past week at the AAOS meeting, and Andy has a really interesting job. He's an orthopedic surgeon in London and a brilliant guy. And I asked him about this paper, and I asked him about quad tendon, and I asked him about hamstring, and I asked him about allograft. He said if he even suggested anything but a patellar tendon graft to a Premier League soccer player, he would get laughed out of the industry. He would probably lose his job, and nobody would ever come see him again.
Mhm.
And he's the guy that does all these Premier League guys. And I was shocked. He also said I used to do hamstrings for all these guys, patellar tendon in the last 8 to 10 years. And he literally said if I even suggested it to them, I would lose my job.
Wow.
Yeah.
So,
Well, Doc, I'm glad you brought up the point about the quality of the study. One of my mantras is you have to look beyond the levels of evidence
Mhm.
for the quality, as you
Right.
mentioned, because a lot of this literature has a ton of selection bias, but
Mhm.
that's what orthopedic surgery, forgive me, is about. It's about choosing the right patient. And
Mhm.
if you look in here and you look at the inclusion exclusion criteria, that should tell the story. You're not Adrian Peterson. You have to fit at least this, right? And then you have to go through this gregarian protocol that no one, as we've said, is going to really be able to do. So while what I love is how they call it a pragmatic trial. Yeah, right. This is not pragmatic. This is very pie in the sky stuff for me.
I'm not signing up for that.
No.
The other thing I was going to say too, and Kevin, I just wanted to agree with you and with what Phil just said, is that if you're going to throw something like this out here that somebody's going to pick up in the news media, this is against decades of really good research, right? I mean, it's against outcomes that speak for themselves. And I think that we have to, realize that too. And back to what you're saying about your friend, Dr. Dugas, who does the Premier League. I mean, we've got some new players in the game, right? We've got this quad tendon. I just had a friend call me, and she had a female athlete that had 2 quad tendon repairs, both of them failed. And now they're going after patellar tendon. And so it's like, we've got decades of experience with this stuff.
We do. And I also think that there's other factors in play. When you have a study that shows that non-surgical management works for something, you can count on the industry, the insurance industry, the insurance
Picking that up.
lobby to pick up on that and tout it and try to get that across the goal line. So, some of these things are driven in ways by people and things that we don't touch. So,
Right.
How could these, so if they're immobilized for in 90 degrees of flexion for 4 to 6 weeks, how can they not be a little stiff? Because they said in the article that rarely was there problems with stiffness.
Yeah.
But it seems, Kevin, don't you think they'd be stiff after 4 to 6 weeks of no movement?
Yeah, absolutely. Years ago, and again, these aren't reconstructions, but years ago, we used to put people in a cast at 30 degrees, right? Or
Yep.
brace at 30 degrees and lock them. And
Yeah.
that was after reconstruction. But I did see back in the day when you people weren't born, evidently, Rob, you were in kindergarten or something, a young
Ashley wasn't born, I can tell you that.
Yeah, Ashley
right, a little tyke.
but
But I did see in Chicago where they recommended putting people in a brace for partial ACLs. And Dr. Noyes did a classic study, JBJS, I think it was like 83, the rule of thirds, where that he looked at them arthroscopically, if they had a certain percentage versus certain percentage, how well did they do over time? Now, he was pioneer enough to get a second scope. Nowadays, you're not going to get a second scope just to take a peek. And he showed about 2/3 of those partials didn't do well, even if you immobilize them. Now, again, that's, a little bit different times and different immobilizations. Basically, it was at 30 degrees of flexion.
Yeah, this seems like a lot these days.
Yeah, I
Lori,
think,
Lori Bogla asked, Lori is on all the time. Lori, thanks for watching again. She's been, since we had her on, she's on like every single one of them, I think, and always asks good questions. How long does it take her? Her question was really asking about the cartilage health of having the knee immobilized for that long. How long can you immobilize a knee where you have really no movement before your cartilage starts to deteriorate? How many weeks does that take?
Not weeks, it's days. It starts
Just
to change.
days.
Yeah,
So
there's some
4 weeks
classic
is definitely a
studies.
problem.
Yeah, from the University of
Fluid
Florida.
moving. Yeah.
Its chondrocyte changes within days after immobilization.
Yeah, that's a problem then for sure.
Yeah, no, it's a great point. I'm glad she brought it up.
Yep.
The other thing I was going to say is when it does make the national news, I think the bad part is, and Phil made a great point about the study, is I think it's confusing to the consumer, to the patient. Dr. Dugas, you're saying surgery. I mean, he's a surgeon. He wants to do surgery. Maybe this is the way to go. And it's, it's not tested. It's not documented. There's no long-term follow-up. And, you want to do right by your patients first and foremost. And, for me, that's the little bit of the hang up with this is no long-term, no control group, no comparison. We don't know who these people are. Some major flaws. I'm kind of surprised it was published in the British.
Yeah.
But
Yeah. All right. Well, we have like 10, 11 minutes left. So before we're all done, Kevin, the last article we have is your article that you did with Zach Thomas, Chris Arrigo, and the General George J. Davies. And the article is the need to change return to play testing in athletes following ACL injury, a theoretical model. Tell us what your article's about and what we should be doing different.
yeah, I mean, the quick synopsis is I think we have good return to play testing. I just don't think it's good enough. When you have some of these studies, and I haven't quite seen the numbers that some studies show, like a 20% failure rate and things like that. I think that happens sometimes when people go back ill-advised to sports. They run out of visits and they just kind of do their own thing and they don't see a physician. I think if people are monitoring, when you look at a university setting, I use the University of Alabama, for example, or Troy University, when they have an athlete that's reconstructed and you got trainers and therapists on that person, the failure rate is so low. I mean, it's less than 5%. It's like 1%, 2%, because they're not letting them go back until they're ready. So the point that we tried to make in the study, instead of these superficial type tests, if I might call it that, where we do an isokinetics, which is fine, and then maybe you do a hop test or shuttle run, we wanted to do reactive testing because the majority of injuries are unanticipated reactive movements. So instead of doing a hop test when you stand on one foot and you hop out as far as you can or crisscross over, which are all great tests, don't get me wrong, but they're entry level tests. Now, when you push off, as you push off, we tell you which foot to land on, or we tell you which side of the tape to land on. The shuttle run, instead of running and hitting the cone and then cutting to the right, predetermined, we stand there and we point the direction, or we use blaze pods where it lights up and they can't tell. And it's really interesting. Lately, I've been comparing my directions to blaze pods, and the numbers are different. Timing. The lights actually throw people off more because they're kind of, they're searching more versus a hand that does this. I don't know what the right answer is, but for me, shuttle run, hop test, traditional gets you maybe doing some training. But if you're going to say to this high school girl soccer player who's at a high risk for a second ACL, for me to say you're ready, I'm going to put you through a battery of tests because I'm putting my name on you. Do you know what I mean? I'm putting my reputation on the line to say that to that mom or that dad, you're ready to play. And I take that seriously. And I know you all do on this call as well. So I want to make sure you're ready. Especially if they don't have trainers at the school or they're not testing at the school. We need to get very, very specific with our tests.
I think there's several studies out, Kevin, showing that, and I'm sure you know these, that show that really probably, I don't know what percentage, maybe 20% of therapists actually do return to sport testing at all.
13
This
according
is
to
crazy
Dr.
to me.
Noyes'
It's just
paper.
crazy.
Yeah, it's 13% use objective testing.
13% do use
13%.
objective testing, which
That's horrible.
yes.
And the paper by Lynn Snyder Mackler show that if you use objective testing, you don't go back before, 6 months, you push it to 9 months beyond, you have symmetrical quads, you reduce your re-injury rate substantially. But, I mean, let's face it, people run out of visits and they get turned loose a little bit quicker than we all want, or they do their own thing. It's a tough dilemma right now.
Kevin, what do you think the reason is people don't, what the other, so what is that, 13%, 87%? What's the reason the other 87% Is my math right? It is, isn't it? 87% don't.
Well,
What's the reason?
I think I'm going to blame some people, if you don't mind. I'm going to blame the physicians. Some physicians lose track of their patients. They don't do follow-ups. They do an office visit, the shake test, the squeeze test, and they ask them, what are you doing? And they trust the patient. I get that. But like Andrew Sports Medicine doctor, they send them to be tested. They send them all the time. Or they have the trainer at the school test them. I know that for a fact. So it takes another level of commitment. The other thing is, it's also the therapist to say to the patient, hey, Rob, all right, I know you're running out of visits. You're 5 months. You need to be practicing. I know you're out of visits. You need to come back at 6.5 months and I want to test you. We'll work it out. Maybe we charge you a couple bucks. Maybe we do it for free. You know what I mean? It's a commitment to sports medicine. If you're doing sports medicine, you have to make yourself available. You have to go the extra mile. You have an obligation to the athlete, to the patient, in my mind.
Actually, your patient. Yeah. Yeah.
Yeah.
Question from Steven. In your experience, do coaches, athletic trainers put returning athletes through their own battery of testing before actually returning to sport generally?
Yeah, absolutely. The trainers I work with, as far as just collaboration, University of Alabama, they have their own tests. I mean, we've talked about them. They do some of my tests, but they have their own that they use. A lot of them use GPS stuff as far as acceleration, speed, workloads. All those things are factored in, especially at the university level. My problem is the high school. That's my problem. Some high schools are great. Some high schools inner city. Let's face it, they just don't have the resources. They don't have a
They're
trainer.
so often
That's
underserved.
right.
I know.
And some work from the Moon Group and Kurt Spindler has shown social economics play a key role in your success rate with ACLs. They published 2 papers on that. And I'd love to hear Dr. Dugas' opinion, because I'm sure some of your kids are calling and the mom, hey, can they go back? And, how do you handle it?
Sorry, I was answering some of these questions in the Q&A thing. So what was the question? Sorry.
What about, you got a high school kid who maybe doesn't have a trainer at the school, or maybe they're just a recreational one. How do you address it when they call your office and say, hey, can I go back? I'm 7 months. You said, probably around 7 to 9 months, I could go back.
I always try to get the parents and the kid to look at and I ask the parents, I am fond of asking the parents, do you mind if I parent your child for a minute? They always say, sure, doc, no problem. You have to have a discussion with them about the risks and the benefits. I can quantify the risk for you, and I can tell you what the risk of going back early is. Can you quantify the benefit? And
But how do you know if they're ready?
Yeah.
How do you know if they're ready?
So
what
I always say is, I want you, the grand test, the isokinetic test is not the grand test. So I want them to do a functional assessment. I want them to do a ramp of agility. I want them to do functional things and see if they can do it. One of the worst things that I could say is, sure, go play. Just go from nothing to playing soccer or playing defensive back from just running, jogging. So go from jogging to being a defensive back in high school football. That person's going to get hurt. And I need to not let that happen. So I am a fan of talking to them about risk and benefit. And if you really lay it out for them what the risk and the benefit is, rarely are you going to find a parent or a coach that is going to, I've never met a coach that would hurt a kid. And I've rarely, if ever, met a parent that was so hell-bent on seeing their kid play that they would risk them getting hurt. You'll meet kids all the time that'll say, I want to play, I want to play, I want to play. But the parents and the coaches, I think, ultimately, they're going to do the right thing 99.9% of the time. And I think if you lay it out for them, ultimately, there have been a couple of times where I've said, you know what, I'm not writing a letter. I'm not writing you a clearance note. And if the parent wants to clear them, they outrank me. The parent outranks me in high school. Above the high school level, they don't. And I just don't see many coaches willing to play a kid without me saying they're cleared.
Safe, yeah.
I've seen it where they've tried to throw them early. That's for sure.
Oh, no doubt, they do that all the time.
I think the biggest key for the people that are listening, everybody on our panel tonight does it, is if you get the trust of the parents and you get the trust of the kid, whatever the kid means. That means anybody younger than me. You win them over. And just like Dr. Dugas, the risk benefits, that's one thing saying it, but if they don't trust you or they don't believe there's a chance that they can get hurt again and you're not sincere about it, you lose them. Whereas if you're sincere and they trust you, you got them. They're not gonna risk it.
Actually had an interesting situation with that exact. I had 4 girls one year, all from the same volleyball team. 4 girls tore their ACL in 3 weekend tournaments. I rehabbed 2 out of 4 of them. The other 2 lived too far away. They saw someone else. But the director of the volleyball club wanted me to clear all of them to do all their return to sport. And I told all 4 of them they weren't ready. And the 2 that were my patients listened to me because I had the rapport, I had the trust, all of that. The other 2 were like, whatever, went back. Those 2 tore their contralateral.
Yeah, opposite.
My other 2 stayed out longer and went on to play college volleyball. Obviously, isolated, interesting case, but to your point, like the rapport is such an important piece of that decision making.
Yeah, I mean, the people that are on the call, just be perfectly frank with them and show that you care. And that's what gives them the trust. That's where you get the trust from.
Love it. Love it. Well, I wish we had more time. Where I think our hour's up. We have a bunch of questions that I wish we could get to, but I guess that happens when you got great speakers.
Well, I guess
I'm
we can
trying
go
to
around the
answer as
horn.
many of them as I can.
Yeah, he was. We'll go around the horn though. There's a couple questions on graph choice. Everyone want to? I think I know the answer, but
The gold standard is the gold standard. I always say Kevin is the GOAT. The GOAT is the GOAT for a reason. I don't need to explain why he's the GOAT, but he's the GOAT. Patellar
no one
tendon
on this
graft.
panel that would go against the GOAT.
Patellar tendon
No
is
one.
the GOAT, and it's the GOAT for a reason. And until it's not the GOAT, it's still the GOAT.
And I think for the rehab people on is each one of those graphs have uniqueness to them and
They do.
potential problems, so patellar tendon graft might have a little bit of a problem with anterior knee pain. So you have to get the patella moving, get your knee flexion, get your full extension right away. But as far as these people that say everybody gets tendonitis, that's nonsense.
That's not true.
Right.
Quad tendon, tougher to get your quads going, harder flexion. So just be aware of that. Hamstring grafts, hamstring weakness long term, less pain, easier rehab, but soft tissue to bone healing, got to be careful.
Slower
Not
now.
a great idea, not a great idea for females in my mind, not a great idea
Right.
for people who are not going to be trustworthy and bump up their rehab. So each one of those graphs have pros and cons.
And I'll say that I think not all those are the same. Patellar tendon grafts rehabbed properly and bone grafted and closed the defect makes a difference. Hamstrings, if you triple one of the grafts and get 5 strands, you're not going to see the failure rate, and you rehab them differently. You may lose a little top end speed in an elite sprinter, but there aren't that many elite sprinters out there. And allografts, if I'm going to do an allograft, I'm going to do a patellar. I'm going to use the same piece of tissue I would use if I was using the GOAT. So I'm using patellar tendon allografts, and I sex and size and age match them. So I want something that fits the patient. I don't do soft tissue allografts. I wouldn't take somebody's Achilles and make their ACL out of it. I'm going to use a patellar tendon allograft if I'm going to do it. So I think that there are nuances to these procedures that make them different. And I think taking them just as a class is probably not the way to look at it. People want us to say hamstrings are bad or patellar tendons are good. There are so many nuances to that. I think you ultimately have to do what works best in the hands of the surgeon, what they're the most comfortable with. And there are nuances that make them all fairly equal.
I think there was a study on that, Doc, that actually said what's the best graft? It's the one that the surgeon does the
One you
most.
do the best. One you do the best at.
Yep.
I've never done a quad tendon graft, but I've done 5 quad tendon repairs on full thickness quad tendon ruptures following a quad tendon graft. Now, Robin West and my man down in Texas, Walt Lowe, that took care of the Texans, will tell you they've done almost 1,000 of these things and they do great. My experience in Birmingham has been not very good. And I just, that's very anecdotal, but I
Mm.
haven't had a patient yet that I thought, God, if only I was good at quad tendon, we'd be fine. So it's a little bit like shaving the fat pad. I haven't had a patient yet come back that I thought, God, if only I didn't shave the fat pad, we'd be fine here. So I just haven't seen that.
Yeah.
Stick with the
That's good
goat.
stuff.
Stick with the goat.
Stick with it. All right, Ash, you want to close us out? Thanks,
Yeah.
guys.
Thank
Thanks,
you, everyone,
everybody.
for
You
being
guys are
here.
great. It was a great
Successful as
session.
usual. We'll be back March 20th next month for our next one. So thanks,
Thank
everyone.
you very much.
Thank you.
Well,
Enjoy
thank
it.
Thanks
you.
very much.
Thanks,
Good night,
everybody.
Appreciate it.
Good
Bye.
luck to everybody.